Welcome to AETCM, the Emergency Medicine Channel. Today we are going to talk about the resuscitation of the newborn life support as per the guidelines 2021 of the UK. So shall we start? The initial things when we talk about the newborn life support, the factors before the delivery why a patient might be requiring a newborn resuscitation. There are some risk factors which can be divided into antepartum and intrapartum factors. Antepartum fetal parameters and maternal parameters. Fetal causes of would be intrauterine growth restriction.
What are you talking about this one is?
Risk factors for the neonatal resuscitation requirement. Antepartum, like before birth difficulties regarding the fetus would be like intrauterine growth restriction, less than 37 weeks gestation, if there is any congenital abnormality or oligo or polyhydramnios.
So in all these cases, you should expect a neonate
to have the resuscitation to be
because it's a very neonate is prone for arrest in such cases, predisposing
the child to the.
So what are the factors?
Fetal factors are oligo and polyhydramnios.
Grossly dividing fetal factors and maternal
factors. And intrapartum also.
Intrapartum factors.
Okay. Antepartum factors, this fetal factors would be intrauterine growth restriction, less than 37 weeks gestation, like preterm gestation, and multiple pregnancies, if there is a serious congenital abnormality, and oligo or polyhydramnios. Maternal factors would be gestational diabetes, pregnancy induced hypertension, preeclampsia, and if there is any preterm lack of antenatal steroids. Coming to intrapartum factors, in the mothers having evidence of fetal compromise, non-assuring CTG, and meconium stained amniotic fluid, forceps or vacuum delivery, and cesarean section before 39 weeks, or if the mother is under general anesthesia. These are all the risk factors. Next, regarding the area, like the place when we are delivering the baby.
So this can be asked as a question for SB, the Markham SB. What are the risk factors? They'll say some like five points. They'll say, out of which one will be an odd one. So which one is not a
risk factor?
Such kind of questions can ask. So you should be thorough in what are the risk factors. One by one, you should be thorough.
Okay. Next, regarding the childbirth. There are some thermal control recommendations. Standard would be a temperature of newborn should be maintained between 36.5 and 37.5 degrees Celsius. So anything below would be hypothermia, above would be hyperthermia.
So always during neonatal resuscitation, always maintain that normothermia, 36.5 to 37.5. Below 36 is hypothermia. More than 38 is hyperthermia. Okay.
And apart from the child's temperature, even the environment where the child should be born is also regulated. For a term infant, temperatures will be at 23 to 25 degrees Celsius, room temperature.
23 to 25
term. Okay. And for a preterm, that is less than 28 week gestation, we should see that the room temperature will be greater than 25.
Greater than 25. Less than 28 weeks, room temperature should be greater than 25
degrees. And regarding the term,
these are the conditions before you
start even the
planning. This is the starting stage of this thing. You're planning to deliver a baby. Before that, you should be arranging all these things. Okay.
So regarding the thermal regulation, when a term baby or near term, that is greater than 32 weeks gestation baby is delivered, first thing we do is dry the infant and cover the head and the body of the infant with a warm towel.
The thing is, you should be ready with everything. First is preparation.
Yes, sir.
So what all things you require for?
Preparation wise, regarding this,
adequate staff should be there. Okay, you should be well trained, and if you should, you're talking about a pregnant lady who's delivering inside the ER. The neonate. The neonatology on call or the gynec on call, nobody is probably here, or else the gynec on call is here. We are not talking about that aspect. So gynec is here, she delivered. Now it's about neonatal resuscitation. Neonatology on call is not here right now. In the meantime, you should prepare yourself. Call the relevant specialty, like such and such a delivery is going to happen. and make sure you are ready with your staff. The circulation, breathing. Circulation part is assigned to one staff, breathing part is assigned to one staff. The adequate facilities, the warmer, then the
Equipment for adjunct to airway.
Yeah, the cloth should warm with a dry towel, no? Because we should know if it is a preterm, it shouldn't be warming with a dry towel. It's a polyethylene bag. You use a polyethylene bag to cover. You shouldn't be drying it. Which is a term baby, you need a cloth to dry. Then other adjuncts should be there. Because you should be any time you should be ready to face a neonatal arrest, right? Airway compromise, you should be ready with your tubes, ET tubes. So what ET size tube will you?
In newborns, we go
Oxygen
with
should be ready. Oxygen mask, everything. Laryngeal mask, oxygen mask, suction equipments. Then airway. What else? LMA should be ready.
Oropharyngeal, nasopharyngeal also can
Oropharyngeal or nasopharyngeal, everything should be ready. And then uncuffed ET tubes should be used for neonates. Uncuffed. But in pediatrics it's cuffed ET tubes. Okay. And for premature newborn, 2.5 size ET tube is the size. Correct, no? But and for a baby between 1.6 to 3 kg or more, 3 size ET tube. Maybe like it's better to keep around like 2.5, 3 that size of ET tube.
Uncuffed ET tubes.
Uncuffed ET tube. Okay, so that is about the then circulation drugs. What all things should be ready? Adrenaline should be ready.
Glucose.
Okay. Glucose should be ready. Soda bicarb should be ready. Okay, because these are things which we expect. All right. What is the dose of adrenaline?
In the newborn resuscitation, we use 0.2 ml per kg. 1 is to 10,000.
1 is to
10,000.
Okay. Basically 20 micrograms per kg. So how you dilute is 0.2 ml per kg.
1 ampule of.
You take the ampule.
10 ml.
It's 1 is to 1000, right? The ampule is 1 is to 1000. Put it in 10 ml of NS. And then you take 0.2 ml per kg of the thing. That is the dose in case of neonatal
resuscitation
arrest, the neonatal cardiac arrest. Okay, so be ready with all the adequate staff, the equipments, the drugs, all the facilities, and call the relevant specialty also in advance. And then you wear your PPE, everything. Be ready. Okay, now we can talk.
So first initial will be rapid initial assessment of the child. As soon as the childbirth is made, initially we'll have
antenatally every counseling, everything should be done. Okay, team briefing, what you're supposed to do, assigning roles and everything should be done. Okay, then
we have to assess the tone, color, breathing and heart rate of the patient. Before there is a cord clamping regarding that.
Yeah, we should delay a cord clamping for at least 1 minute. So baby is born, delay the cord clamping for at least 1 minute. Okay.
In that criteria is we should wait for if the resuscitation is requiring immediate effort, we need to immediately clamp the cord and cut the cord. Okay. But we are able to manage if there is a natural breath going on. We can wait for that 1 minute.
If the neonate is likely to deteriorate, immediately clamp the cord and take it out. Otherwise, if there is no likelihood of deterioration, you can delay the cord clamping for at least 1 minute. Okay, then
rest. If there is no time, then we can even try for milking the cord if the baby is greater than 28 weeks.
Okay, milking the cord.
The cord.
All right.
Then we'll come to the component of assessing the baby, initial assessment.
No. Then start the clock, note the time. We're talking about the neonatal resuscitation as per the
UK
resuscitation council guidelines. So start the clock, note the time, dry, wrap and stimulate the baby. Okay, for term babies. Dry, wrap and stimulate. Okay. How do you stimulate?
We stroke the back of the heel or the back.
Or the back, gently. It's not gently, you can stroke the back of the heel or back Okay. Ideally, the baby should cry, right? Okay. If it's just smiling and all, it is not enough, inadequate. If it's not responding at all means it's critical. Okay. But in case of preterm, you are not supposed to what?
First, we need to wrap it in the polyethylene cover.
Yeah. Place the neonate untried in a polyethylene bag. Okay. And then that radiant heat should also be done. Everything should be done in a warmer. Okay. All right. Then, so baby is born. Yeah.
Then initial assessment components will start. First, it would be the rapid initial assessment, which should be done even before the umbilical cord is clamped and cut. We need to see the tone and the color of the baby, the adequacy of the breathing and heart rate. Regarding tone and color, if the patient
basically assess the color, tone, breathing, heart rate. CTBR. CTBR. That's almost similar to that Apgar score we used to
same
way. But here, according to this algorithm, you assess color, tone, breathing, heart rate. So what in color?
Color basically is just to see the oxygenation status, like if cyanosis is there or not, but it's difficult to recognize. Paler would indicate that patient is in shock. Apart from that, color has
also
not
congenital abnormal heart cardiac problems also cyanosis. Okay. Then
in breathing we need to see the rate, depth, symmetry and work of breathing. Depending on this, we classify breathing as adequate, inadequate or absent. Inadequate will be...
So basically RR, depth, symmetry, work of breathing. This work of breathing can again be divided into adequate, inadequate and absent. Okay.
Inadequate means gasping or grunting kind.
So these are the things which we are supposed to look at. If it's inadequate, see whether it's gasping or grunting. Okay.
Then heart rate. We can connect tone either floppy or the
floppy, reduced or good tone. Okay. Then
heart rate. Heart rate, depending upon the monitor, we can connect to the monitor and see the heart rate, or the ECG, 12 lead ECG can be taken. Like heart rate greater than 100 means it is satisfactory, greater than or equal to 100. If it is
100 or more,
100 or more satisfactory. Okay. 60 to 100 it means intermediate. There can be a possible hypoxia in the child. If it is less than 60, it is critical and hypoxia is more likely to be there.
Okay.
After this we classify.
This is about color, tone, breathing, heart rate. So in this, like unlike adult resuscitation, there we'll be checking at A, B, then C. Here you will be assessing together. Both B and C will be assessed together. Like if you say color, tone, breathing, heart rate means everything is together. Okay. So after this CTBR assessment, how do you?
We classify depending upon the CTBR assessment into satisfactory, incomplete and poor. In satisfactory, we consider satisfactory transition when the baby is having good tone, vigorous breathing or heart rate is fast. When these three are there, we can say the patient is
fast means heart rate 100 or more.
100 or more.
Okay, the baby is having good tone, having vigorous breathing, crying, and heart rate is 100 or more. That means that it's a normal baby. So it's a satisfactory transition to normal life.
In that baby, we no need to give breathing support and heart rate is acceptable. So in that, the action would be delay the cord clamping for 60 seconds. And then dry the baby in the warm towel and keep it along with the mother and promote the early skin to skin care if possible.
Okay.
Next comes incomplete transition, where there is reduced tone.
Here comes our role.
Yeah. First, satisfactory transition
means it's a normal delivery, nothing to worry. Okay. Then incomplete transition.
Incomplete transition, there will be reduced tone. Breathing will be inadequate, that is grunting or the gasping kind of a breathing. And heart rate is slow, that is 60
or
to
even
100. Apneic or
heart rate less than
100.
Less than 100. Okay. So one question in MCQ and all you can get is heart rate is 100. So people often get confused. People like, is it like 100 or more? Like whether it's a satisfactory transition or incomplete transition. They straight away say 100. 100 stands in what? Satisfactory. Only if it is probably 99. Till 99 only it is Unsatisfactory. Okay.
In incomplete transition, baby requires breathing support, and as if there is a slow heart rate, it may indicate hypoxia is there. In this baby, we can do only delayed cord clamping if there is able to do appropriate support to the infant. Simultaneously, if there is appropriate support can be given, then we can do delayed cord clamping. Or if the baby is greater than 28 weeks, milk the cord and cut the cord.
Yes.
And we need to dry stimulate wrap in the warm towel. Standard we have to do, and maintain the airway by doing lung inflation and ventilation, following the steps of the newborn resuscitation.
Okay.
Next will be the poor or failed transition. In this, the baby's tone is floppy or color is pale, and breathing is inadequate or apneic, and heart rate is very slow, that is less than 60. Here is less than 60.
Okay.
And in this also again breathing will require support, and heart rate less than 60 will be considering significant hypoxia. So in these cases the action would be immediately clamp the cord and shift the baby to the resuscitation platform, and that resuscitation platform should be previously radiant warmer should be placed so that the baby will be in
Radiant warmer is a must. Okay.
must. Apart from that, continue this newborn resuscitation guideline for this.
Okay.
The only difference
for your MRCOM, OSCE examination and all, this is what you're going to get. Even FRCOM, OSCE or MRCOM, OSCE, in one station maybe like newborn resuscitation. Okay. So either the child can be in incomplete transition stage or failed transition state. Mostly it will be failed transition state. So there you will have to go according to the algorithm. Okay.
The difference in the preterm infants is that we need to consider additional methods for thermal care, as in polyethylene wrap, and immediately as soon as the preterm baby is born, connect the saturation probe and or get an ECG done. And if the patient preterm baby is naturally breathing, help him with CPAP.
Either connect with the nasal prongs or a
face mask.
And connect with the CPAP. Okay.
Now,
and always ensure an open airway, no?
Yes.
Okay.
Now, with regarding the newborn life support, the resuscitation, we either
what is the acceptable preductal saturation? Preductal means right hand.
Right.
Okay. What is the acceptable preductal saturation?
If it
for
is
for a preterm?
For a preterm, less than like 28 weeks, we need to put FiO2 of 30%.
Basically at 2 minutes, not only preterm also, at 2 minutes you expect a preductal saturation of 65%, 5 minutes 85%, and 10 minutes 90%. Okay.
Our target would be maintaining the oxygen saturation in the top 25 percentile as per this.
Yes. So you shouldn't be expecting 100% saturation in that. Unlike adults, you shouldn't be expecting that. Okay. All right. Okay, then.
Sir, regarding this intervention to continue the respiratory support which we need to intervene, if the baby is not having adequate breathing or if heart rate is less than 100, then we continue with the algorithm. First, regarding the airway, as per the algorithm, first 30 seconds would be the assessment. Within the first 60 seconds, the assessment and the 5 rescue breaths should be started. If the baby is, as per the assessment, having any difficulty in breathing or this heart rate less than 100, initially 5 rescue breaths are given. This all should be completed within 60 seconds of the time clock which we start. But
rescue breaths or inflation breaths?
Inflation breaths.
Rescue breath is different.
Which
that is for pediatrics. Initially, before CPR, you do a rescue breath, give 5 rescue breaths. One rescue breath is over 1 second. And then you start CPR, because when mostly in pediatrics, neonates, everyone, hypoxia is the main cause of cardiac arrest. So that's why you give priority to like the oxygen saturation. But in adults, you go with CAB, right? Okay. So in this case, it's not rescue breath. It's a once you have confirmed it's an open airway. Okay. Once you are quite sure that the baby is having an open airway, you give a inflation breath. Okay. If the patient is gasping or not breathing, that is the point. Okay.
If the patient is gasping, not breathing, or heart rate less than 100.
Yeah.
Then we start with this.
No, heart rate less than 100. That criteria, we are basically now in the B part.
Okay.
So here we are talking about what? If the patient is gasping or not breathing, then you give inflation breath. So before that, how did you check whether the patient is having an open airway? Like,
that regarding the techniques to see the open air, we need to place the baby on a flat surface, flat line.
a neutral position.
Neutral
Baby has to be
position. With neutral position in sense means the glabella and the chin should be in the straight line. The anterior surface of the neck should be wide and open, not bent forward. And the external tragus and the suprasternal notch again should be in the straight line.
Yeah.
These three things, if it is, that is the baby.
That is the neutral position.
That is the neutral position. For that, we can keep a shoulder roll below the shoulder blades and headrest also, so that everything comes in a neutral
Because
position.
baby's head will be large. Compared to for pediatrics, it's like that.
Right.
Okay, so there are high chances that the child may bend like this. So keep it in a neutral position.
Second thing regarding the maneuvers, we can do jaw lift.
Now, after keeping in neutral position, if not still not improving, you do a jaw lift. It's not called jaw
Jaw
thrust.
thrust. We press both this mandibular and lift the mandible.
Okay. If still not improving,
If still not improving, then we can go with intubating the
two-person airway.
first initially would be the 2%
2% airway support.
2%,
Then the laryngeal mask. Then the OPA.
OPA and PA.
OPA is oropharyngeal airway. NPA is nasopharyngeal airway.
Then ET tube.
Okay. Then
Next
after doing all these things, if the patient is breathing, nothing to be done. But the patient is not breathing properly, or if the patient is gasping, then you give inflation breath. Inflation breath means
inflation breath is like giving along with the face mask.
you keep a bag valve mask over the child's face, the adequate size bag valve mask, and then you give inflation breath over. It's not over 1 second.
3
seconds. 1 second is different. That's rescue breath. This is inflation breath. Breath is given over 3 seconds. 1, 2, 3, 4. Like 3 seconds is the time to
One breath.
for inflating. You're basically inflating the chest. You're dealing with B, breathing. So some problem is there in the breathing part. So you're inflating the chest over a period of 3 seconds. And similar 5 breaths will be given. So that is called inflation breath. Okay. And what do you expect?
We expect the chest rise and
Basically we should see for adequate chest rise is there or not. And apart from chest rise, you should also see whether there is a appropriate level of increase in heart rate. We are basically expecting to increase the heart rate to more than 100. Okay, so your target is until you give 5 inflation breaths, see whether the
heart rate is appropriately increased and saturation as per the time.
As per the time is increasing, and there is adequate chest rise. If not, suppose you are not getting adequate increase in heart rate, then see if the chest is moving or not.
That would be a better indicator regarding the inflation.
If the chest is moving, means we have already taken care of the B. Breathing. Okay, you continue.
So like first after the 5 inflation breaths, again 30 seconds assessment will be done. Still again, if there is any breathing difficulty still there, we can have the adjuncts to this air.
30 seconds. What did you say? I didn't get it.
Every 30 seconds we assess. After the 5 inflation breaths, again we reassess.
That means it will be 15 seconds. 5 inflation breaths.
Along with that, yes, sir.
15 seconds, right? 5 inflation breaths, each inflation breath over
3 seconds.
3 seconds, which will come to 15 seconds, right? Right?
Yes, sir.
And then you reassess. Okay.
Reassess. Okay. In reassess, if there is again no increase in heart rate, then we look for the chest movement.
Okay. In the meantime, you will be connecting all
saturation probe.
All monitors, saturation probe, cardiac monitors, everything should be connected. Okay. Everything should go simultaneously. Okay. Then.
So if the chest is not moving now, after the first rescue inflation breath, if the chest is not moving, then we can reassess the airway part. Like check the mask, head and jaw position. Equipment we have to check. Next, 2% support, like a single airway. 2% we can do then. And consider suctioning laryngeal mask on tracheal tube right now. If that also not there, then we again repeat the inflation breaths.
Okay. So in B, what happens is there are 2 interventions in B. One is 5 inflation breath by a single person. If not, working, if this is not working, see whether you're doing it properly or not. The B part is their way, the positioning, all these things are proper or not. If you're confirmed that you're doing it properly, then go with 2% technique. 2% technique also, again another 5 inflation breaths. Okay.
Yes, sir.
So that is also 15 seconds. Alright. Then, so basically 2 interventions in breathing are there.
First intervention is the
Single person inflation, 5 inflation breaths. Then
if that is not working, then we can try
2% inflation breaths. And then basically you can also do suction, laryngeal mask, trachea tube, all these things can be
If
considered.
still the chest raise is not there, we can suspect airway obstruction. In such a scenario, airway obstruction, suctioning is allowed, but suctioning is allowed only under observation. We need to visualize
Randomly, you shouldn't be going and doing a suction. If you're able to see, you would do.
If we see any mucus, meconium, blood clots, anything, then we can suction it out.
Okay.
But if there is meconium and there is very deep level till the alveolar level, the meconium, then it was advised to intubate the patient and through ET tube to suction it out.
Yeah. If there is some foreign body or anything you're expecting because of that is the arrest and all, you'll have to intubate and take it out. Or if there is some surfactant and all, so deficiency and all, also you'll have to intubate. Some specific.
If you there's a in certain cases intubation would be helpful, like if there's a congenital diaphragmatic hernia, or if you want to give surfactant to the kid, better we intubate it and then through the ET tube we can provide it.
Yeah.
Again, regarding the lung inflation, regarding the inflation breaths which we are discussing about, the pressure would be up to 2 to 3 seconds we have to give as told. And inflation pressures for a term baby is 30 centimeter of water and preterm is 25 centimeter water. And the FiO2 which we give with the inflation breaths will be, if it is greater than 32 weeks, 21% FiO2 is enough. If it is 28 to 32 weeks, 21 to 30% of FiO2. If it is less than 28 weeks, 30% of FiO2 is used. So even after such techniques, even if the patient there is no increase in heart response and chest is not moving, there are few things we need to do, like check the equipment if it's working properly, and recheck the head position and jaw lift. If recheck the mask size and position of the seal, then consider the other airway maneuvers like putting 2% mask, or inspect the pharynx to see any obstruction and under visualization suctioning it out. Next would be securing the airway using LMA, ET tube or oropharyngeal, nasopharyngeal.
So right now we have already now taken care of the B. Okay. So B is okay.
Yes.
Now you reassess
it again. And right now if there is first chest movement,
you will have to see whether the chest movement is there or not. Now chest movement is there. See, suppose it's there, but heart rate is still not
less
improving.
than 100.
Still less than 100. So what to do now?
Now we'll come into the C component.
Now we are in C. Okay.
In the C component, first important thing would be ventilate for 30 seconds. We consider hypoxia to be the more important cause rather than the heart compromise.
So then in this case, if
first
in C we have got 3 interventions. One is you give a ventilation breath. That means ventilation breath, it's not 3 seconds, it's 1 second. So 1 second for 30 seconds. Okay, that is called ventilation breath. So you give 30 ventilation breaths. Okay.
For 30 seconds. And then
one breath every second. So that comes to 30 ventilation breaths. And then you reassess. Reassess in the sense you are basically, what are you looking for? Increase in heart rate. If the heart rate is still
less than 100, then with the second
less than 60 or not detectable.
Yes, sir.
Okay, not less than 100.
No, less than 60 or not detectable.
Okay. Yeah. Then what we are basically concerned is less than heart rate less than 60. Okay, because less than 60 means it's the time you should consider cardiac arrest in a neonate.
Yes.
Okay, but straight away you can't go and do a chest compression CPR. You give ventilation breath first. Once you have taken care of the A and B, go to C, give a ventilation breath for 30 seconds, and still after 30 seconds, heart rate is not picking up, not increasing to more than 60. You go ahead, do a CPR without drugs. Here
in this CPR would be 3 compressions to 1 ventilation.
Yeah.
So like that 15 cycles over 30 seconds is followed.
Okay, 3:1.
3
That
is to
means
1.
3 compressions, 2 thumb technique.
Two thumb.
2 thumb technique will be doing here.
Yes, sir.
3 compressions, 1 breath. 3 compressions, 1 breath. How many such is there?
15 cycles.
15 cycles you do.
Yes, sir.
Okay.
And at this point, when the CPR is started, FiO2 will be increased to 100%.
Okay.
And considering at this point, we can consider ET tube or laryngeal mask.
If not already done.
If not already
Not
done,
already done, we can consider
this.
Okay.
After this 30 seconds, again reassess. If the patient is still in heart rate is less than 60, then we will start with drugs, CPR with drugs.
Now CPR with drugs.
Drugs.
Okay. But before the drug, you should put a cannula also.
Cannula.
But where to place?
Usually the umbilical vein would be the
Umbilical
most
vein is most
used to think. If we are not having difficulty to cannulate the umbilical vein, then we can try with the intraosseous route, IV route. And if the patient is intubated, even you can give through endotracheal tube. So regarding drugs, our during resuscitation, major drug would be the adrenaline.
Okay.
The dosage of it would be 0.2 ml of 1:10,000 adrenaline concentration.
ml per kg.
0.2
ml per kg of 1:10,000 adrenal dilution. So you take adrenal, whatever we have the 1:1000 dilution thing.
Ampule, yes.
Dilute it to 10 ml and then take
0.2
ml per kg. In the meantime, before that, you should know the weight also.
Yes, sir.
Quickly, you can just measure the weight. Otherwise, you won't be able to give the. Okay, then.
Then other drugs requiring in the CPR would be dextrose.
Yes.
10% dextrose solution we can take. That
has been done already during preparation itself. Everything is already ready.
Yes, sir.
Otherwise, all of a sudden, this time you're not in a position to. Should be ready with all your drugs. Okay.
Here it would be 2.5 ml per kg of 10% glucose solution.
Child is like babies are very highly prone to go into hypoglycemia. So it's better
if there is a prolonged this cardiac resuscitation going, we have to consider hypoglycemia and we have to start with this one.
So 2.5 ml per kg of 10% glucose solution. It's not 25% dextrose, it's 10%. So these are very like catchy questions like MCQs and all. No? They'll confuse you with these things. 2.5 ml per kg of 25% dextrose, 50% dextrose, 10. So it should be each and every point is important in this newborn resuscitation. So you can get 100 questions from it. Okay.
Next, if they are considering any blood loss or shock in the patient, then we need to start volume bolus fluids. Okay. The bolus which we consider here will be 10 ml per kg, either crystalloid fluid or O negative RH. O negative.
O negative is preferred.
10 ml per kg bolus.
10 ml per kg. That is important. The weight 10 ml per kg.
Next, if we are considering to be an unresponsive resuscitation and intracardiac acidosis is there, then we need to give sodium bicarbonate. In that we give 1 to 2 millimole per kg. Sodium bicarbonate.
Slow IV.
Slow IV, yes, slow
okay.
IV.
2 to 4 ml per kg of 4.2% solution. That is what they recommend. Okay.
These are all CPR with the drugs.
Okay. So in circulation, ventilation breath for 30 seconds. If failed, CPR without drugs. Then if failed, CPR with drugs. Okay, and correct the reversible causes also. In the meantime, what are the reversible causes of this thing?
Reversible factors would be like we have to rule out tension pneumothorax, hypovolemia, and equipment.
Pneumothorax. They haven't mentioned tension pneumothorax. Because we are not expecting any child pediatrics and tension pneumothorax. We are not expecting. They're saying pneumothorax, hypovolemia, congenital abnormality. These are the 3 points that they say. Okay. But probably acidosis will also be there.
Because that is why prolonged hypoxia. And
yeah, but that is why we have mentioned about soda bicarb. Okay. Yes. That is also one. These are the child, you are not expecting this thing, ACS, coronary event, or nothing of that. So most of the cardiac arrests are because of hypoxia. Pediatrics. Other things are very less likely. Okay. Then comes hypovolemia probably because of some reason. Very like hypoxia is the most commonest cause of all. Even with the minimal fluid and even if it's hypovolemia, shock and all, child heart will still be beating. Okay, it's not like adults. Okay.
Next, we go with the post-resuscitation care. In this, important point would be the glucose levels after resuscitation should be maintained. Both hypo and hyper should be avoided. Next, thermal care. In thermal care, we should maintain the temperature from 36.5 to 37.5 degrees Celsius. We should avoid both hypo and hyperthermia. But there is a concept of therapeutic hypothermia. This can be allowed only if we are documenting that the patient the child had undergone
Therapeutic
hypoxic
hypothermia,
induced.
therapeutic adults, it is called targeted temperature management. Here it's still called therapeutic hypothermia.
Intentionally getting the patient to hypothermia.
That is between, we'll have to keep it
33
between
to 34.
33 to 34 degrees Celsius. Okay.
If the patient is being considered to have moderate or severe HIE, hypoxic ischemic encephalopathy, only in such patients we target the temperature 33 to 34. Otherwise, we should avoid.
Yeah.
After documenting it only, then only we can target
Otherwise, it may cause more harm.
more harm.
Okay.
Then we
So always after doing all these things, clearly document. Document as evidence what all things you have done, on what basis you have done all these things. Okay.
and communication with the parents whenever.
Including that cord blood gases, and even if you give bicarb and all, everything should be there.
Yes.
Cord blood gases, neurological examination, everything should be done, and then clear documentation, communication with parents.
And this in this algorithm regarding the discontinuing resuscitation, if there is a greater than 10 minutes resuscitation without heart rate, detecting the heart rate, then we can consider to stop resuscitation. But heart rate is detected till 20 minutes, the heart rate hasn't been achieved, then we can discontinue the resuscitation. And
After 20 minutes, if you are not able to resuscitate, despite clearing all these reversible causes of cardiac arrest, then you can consider stopping the thing. Maybe after discussing within the meantime, neonatologists will be coming. No?
Yes.
You can consider stopping the resuscitation.
Or if the child is having greater than 90% predicted morbidity and mortality.
Yeah, underlying this thing itself is so poor.
Discussing with the parents, we can withhold resuscitation procedures.
The chance of cardiac arrest is really very, very mega percentage, a 0.0 something percentage, especially in neonates. Mostly it happens with all people having all these predisposing things which I already mentioned,
Risk
factors and underlying cardiac abnormalities of the child. They are at high risk of arrest. Okay. What is wet flag?
Wet flag is this scale of the drugs.
Do you use it here?
No, we should use
for
it
pediatrics.
in pediatrics.
So for pediatric cases, before you begin with resuscitation, you should be ready with your wet flag. Weight, energy, tube fluids, lorazepam, adrenaline, glucose. Depending on the weight. More than 1 year only you will be calculating the wet flag, not below 1 year. For neonates and all, you shouldn't be mentioning about wet flag. Here the major thing is whether the patient is term or preterm. Okay. That is all.